So I want to introduce Dr. Rachel Lacey, who's going to talk today on obstetric haematology in a DGH in a district general hospital setting. So for those slightly less familiar, the district general hospitals are variable size, but slightly smaller than some of the tertiary referral centres. But really, and this talk is really focused on that liaison between haematology and obstetrics. So Rachel, I'll let you introduce yourself. I think that will be sensible.
Thank you. Hello all. Can you hear me all right? Yeah. Yeah. Good. Okay. Yes. Um, Thanks for asking me to give a talk. My name's Rachel Lacey. I'm a haematology consultant in as Dr. Swallow says, a district general hospital in Buckinghamshire in the UK. So I'm a general haematologist, and sort of I'd say about 90% of what I do is actually malignant haematology. So looking after patients with things like leukemia and lymphoma. But myself and one of my other colleagues in this hospital have got a special interest in obstetric haematology as well. So we've set up a sort of relatively small but growing service to kind of look after these patients locally. And obviously, some patients still need referral to our tertiary centre or our big specialist hospital, which for us is Oxford. Um, and I'm just going to focus particularly on um, briefly on the setup in our DGH, and obviously sort of the importance of having a local obstetric haematology service so that patients can access us. And then actually quite a substantial part of my talk is about a difficult case which we sort of managed in um, liaison with our tertiary centre, which, as I say, is Oxford, and was quite difficult for us to manage locally. Um, and of course, sort of I realise that we're talking about a setting with access to kind of lots of specialist tests and treatments, which might not be available everywhere, but hopefully there's still sort of important um, learning points and things we can talk about the management of the case. Please do sort of interrupt at any point. Um, that's no problem. Okay, so obviously, as we all know, haematology is actually a really important aspect of obstetric medicine. First of all, sort of during pregnancy, there's lots of physiological changes that are happening, which can affect maternal blood counts. So there's an increased demand for hematinics, so iron, folate, and women can therefore often become deficient. So that's obviously an important thing that we come across. Things like autoimmune conditions, particularly autoimmune thrombocytopenia. So any woman with a immune destruction of their own platelets, these conditions can get worse during the context of pregnancy, so have to be sort of quite closely monitored. And there's a risk of those antibodies crossing the placenta and affecting the baby. Um, Inherited red cell disorders, so patients with hemoglobinopathies, things like sickle cell disease. Firstly, obviously they're inherited, so could have implications for baby, but also put the mother under at increased risk during pregnancy. So certainly need special input and care. Alloimmune syndrome. So women can develop antibodies to their baby's blood, so red cells or platelets, and obviously that can increase the risk of the baby being anemic or thrombocytopenic. Um, Venous thromboembolism is a really important one. This list is in no particular order, but it's important to note women are definitely at significantly increased risk of venous thromboembolism during pregnancy. And obviously, I mean, certainly in the UK, when patients are first booked in during pregnancy, we tend to think, or the obstetricians tend to think about whether they need thromboprophylaxis, thinking about their risk factors outside just pregnancy itself, but what other specific risk factors do they have? Do they need to go on medications to try and reduce their risk? And what time during pregnancy do we start it? Some patients, of course, are already on anticoagulants, so they might need those changing. Um, some have an underlying increased tendency to clot, so thrombophilias, which can increase the risk of fetal loss, especially early in pregnancy. Obviously, obstetric hemorrhage is another thing that as hematologists we can often get involved in. I actually had a case this weekend of a lady with a big postpartum hemorrhage, 6.5 litres, who had to go to ITU. Um, Inherited bleeding disorders, so things like haemophilia. There's the management for the mother. There's obviously thinking about inheritance and the risk to the child of inheriting the disorder, and then managing the actual labour and delivery and the child at birth. Microangiopathies is another thing. So preeclampsia, can cause abnormalities within the blood in the mother. And also, of course, malignant conditions. So a lot of the cancers we look after in hematology can affect young people and women of childbearing age. So, we have had to look after patients with acute or chronic myeloid leukemia and lymphomas during pregnancy. So, it's quite important that these women have access to a haematology service locally if possible, and then we can liaise directly with the tertiary centre for those that need special testing or sometimes need to deliver their baby in a highly specialised centre. And these are our sort of UK data about the leading cause of death in the UK during 2021 and 2023. And as I mentioned, and I'm sure there's a lot of similarities around the world, that the most important cause in the UK is blood clots. So again, haematologist is of importance. And another really important direct cause of maternal death is hemorrhage. So just to talk sort of briefly about the setup where I work. So as I mentioned, I'm in a general hospital rather than a tertiary centre that's a specialist centre in obstetric haematology. But there's over 4,000 babies delivered a year in our trust. And one obstetrician who's got a particular interest in obstetric medicine who does a clinic once a week. And then there's me and a colleague that are particularly interested in obstetric haematology. And we sort of tend to see those patients in our clinic ad hoc rather than in a specialist clinic alongside an obstetrician. But we have sort of a liaison and an MDT set up with our obstetric services. And in the last year, these are the hematological cases that I've personally seen. And as you can see, sort of by far the most common thing is low platelets in pregnancy. But there's a range of things that we see. So patients with anemia, previous venous thromboembolism. Some have got underlying hematological cancers. So MPN is a myeloproliferative disorder. So patients who've got polycythemia or thrombocytosis, overproducing red cells or platelets. Sometimes we investigate patients with recurrent miscarriage that we think is down to an underlying thrombophilia. And then things like inherited conditions, like patients who have bleeding disorders like haemophilia or von Willebrand's disease. Quite often, they're the patients that we liaise very closely with the tertiary centre, and they'll often end up delivering their baby there if they're considered high risk. But most of this talk is going to be about a very specific case, which was sort of quite out of the ordinary, not the sort of thing we see often. And it was really interesting. So, a 29-year-old lady who was referred by a midwife to us following her routine booking appointment. So she'd sort of attended her antenatal appointment, and she mentioned that she'd had a haematology issue during a previous pregnancy, but we didn't really know much more than that. And the midwife didn't know much more than that. And the patient didn't seem to know much more than that. So at the time she was being referred, we thought she was 11 weeks pregnant with an estimated delivery date of December. She was referred to us in May of last year, and for whatever reason, it took us a month to see her, which is probably about typical. We generally try and find out what's the actual underlying issue with these patients and how far through pregnancy are we and how urgent is it that we see them, and where it's somebody relatively early in pregnancy and obviously it can wait a little bit, but with retrospect perhaps we should have spent a bit more time investigating what this previous hematological issue was before deciding it was routine. So when she attended clinic, she told me she'd had two previous first trimester miscarriages, and she'd got one son who was born in October of 2023, and he's well, but he'd had an issue with his blood following birth, which again sort of didn't give us much more information, but it did tell us that it was something that affected the baby, not just mother. Her other medical history was only really depression. She's a smoker and considerably overweight. Her regular medications were folic acid, vitamin D, which we tend to encourage all patients to take during pregnancy, and she was on aspirin, which had been started by the antenatal team. So when we sort of went back to investigate what was this hematological issue that had affected her first pregnancy, we were able to find that her first baby was born in October 2023 at our hospital. So SMH, Stoke Mandeville Hospital, is where we work. And I could see that this patient had very low platelets, and there was a blood request that I could see on our system, which had the clinical details: unwell neonate, bleeding orally, low platelets, query ITP. And this was their sort of full blood count. So you can see that an isolated, very significant severe thrombocytopenia, but otherwise normal full blood count for a newborn. So I was just going to ask the room if you're able to sort of join in, sort of any causes of low platelets in newborns you can think of. I'm not sure what the setup, whether you're able to shout out. Possibly not. Okay, well we'll go through some. So this table is sort of pretty comprehensive, really, but obviously common things being common, by far the most likely thing if you see low platelets in a newborn is infection, and bacterial sepsis in particular. Obviously, sort of congenital infections, including those that I've highlighted here. So um, toxoplasmosis, rubella, CMV, HSV, syphilis, parvovirus, they can all do it as examples. And if it's infection, then often, obviously, the baby will be ill, the baby will be sick, they might be slow to feed, they might have a temperature, there might be other stigmata which point you in the direction of the underlying infection. So with parvovirus, they sometimes have a sort of classically a facial kind of butterfly rash. They might be jaundice, they might have enlarged liver or spleen. So there are things that might give you a clue. Placental insufficiency or perinatal stress is another important cause. So any intrauterine growth restriction, things like preeclampsia. And in that case, the platelet count will often be mild or moderate and present in the first few days rather than immediately at the time of delivery. Prematurity can often cause low platelets. And again, this is something that's variable and can be multifactorial. So their bone marrow, where the platelets are made, might be a bit immature, so it's not working as well as it should. And they may have other illnesses that contribute as well. Critical illness, so things like necrotizing enterocolitis or DIC, disseminated intravascular coagulopathy, will also cause low platelets. And in this case, you'd obviously expect a very unwell baby, and the platelet count would typically fall over time rather than be extremely low at the time of delivery. Um, and other blood tests would give you clues as well. So we would typically check things like a clotting screen, which I'd expect to be abnormal in the context of DIC. Immune cause. So as I mentioned earlier, women who've got an immune condition, this can be made worse in pregnancy. So some women might have immune thrombocytopenia in the context of pregnancy. These antibodies can cross the placenta and cause low platelets in the baby. There's also sort of situations where the mother has antibodies specifically to their baby's platelets, which is fetal or neonatal alloimmune thrombocytopenia. And in that situation, the baby would otherwise be pretty well. You're not expecting them to show signs of sepsis, but often it's a very severe thrombocytopenia at birth immediately. That's going to be sort of the nadir where their platelet count is very low. And these babies are at risk of intracranial hemorrhage. Other sort of rarer cause, things like bone marrow failure, where they're going to have reduced production of platelets, or perhaps bone marrow failure because of infiltration, which is rare, but a neonate with leukemia, for example, the bone marrow is going to be full of leukemia cells and they can't make platelets. In these situations, you'd expect there to be pancytopenia, so not just low platelets, but low red cells and neutrophils. And again, very rare, but you can get some congenital syndromes which cause low platelets, and often sort of a catalogue of other um, physical features which are associated with that condition. So that's sort of an overview of what might cause low platelets in a neonate and sort of how to differentiate them clinically to some degree. So in this case of this previous child that my patient had had, we looked back at her bloods, at the baby's bloods, and the inflammatory markers were low, the clotting screen was normal. So, it's very unlikely to be sepsis or DIC. And a blood film also gives more information and can be helpful. And in this case, well, there wasn't much to see, but it's important to rule things out. So we could see that the people who'd reported at the time could see that the platelet count was genuine. There were definitely reduced platelets on there. Um, there was no other features to suggest any kind of other issue in the bone marrow. There was no evidence of sort of hemolysis or red cell fragments, which can happen with TTP. Um, and sort of the white cell morphology was normal. So basically, you've got a blood film that just showed an isolated low platelet count, but was otherwise normal. So this previous baby, was given random platelets at the local hospital, and it didn't help at all. Their platelet count remained in single figures. There was no increase in their platelet count. So the baby was therefore referred to the neonatal intensive care unit at our tertiary centre, and they were given special platelets which were negative for a particular antigen, HbA1a. And once they were given those, the platelet count incrementally improved and it normalized sort of 6 weeks after delivery. And thankfully, there was no evidence of any intracranial bleed. And the baby did really well and was well sort of when reviewed in a clinic a couple of months later. So the underlying hematological issue, which had affected this patient's first pregnancy, was FNAIT, or fetal and neonatal alloimmune thrombocytopenia. So what's happening here is the mother, on the surface of her platelets, has is missing one of the antigens that's present on the baby's platelets, and therefore creates an antibody against the baby's platelets. So antibodies towards this HbA1a. So the baby's got platelets with HbA1a on the surface, the mother hasn't. The mother creates antibodies, they cross the placenta and they destroy the fetus's, the baby's platelets whilst they're still in utero. And so um, at the time of delivery, the platelet can be severely low, and the baby can, be at very high risk of bleeding, which in a worst case scenario can cause severe disability or death. Um, Interestingly, the maternal platelet count is normal. So this isn't something that's impacting the mother. So it's not immune thrombocytopenia in the mother. It's specifically an antibody against the baby's platelet count, against the baby's platelets. So our patient had a sort of less common genotype on her platelets, which was 1b, 1b, and therefore, as I've said, was creating these antibodies to HbA1a. And unfortunately, her partner was HbA1a, 1a. So we know that by definition, the baby is going to have this genotype, HbA1a, 1b. So they've inherited 1a from the mother, sorry, 1a from the father, 1b from the mother, and of course, have the antigen the mother hasn't got, which means she's going to create the antibody. So back to the lady that I'm now seeing in pregnancy. As it turns out, this was an unexpected pregnancy and it was actually picked up late. So during her initial pregnancy and delivery, she'd been obviously had to have that emergency transfer of her baby to our tertiary centre, and they had ultimately diagnosed FNAIT. and given the mother information about it and sort of asked her that in future pregnancies to contact them directly, the tertiary centre. But unfortunately, this lady hadn't done that. Um, and when we actually did a dating scan, it turned out she was quite a lot further through pregnancy than we initially thought. By the time we saw her in clinic, she was almost halfway through at 19 weeks. Importantly, she's got the same partner, so therefore we know that there's 100% risk again of the same thing happening because we know that the baby's genotype is going to be 1A, 1B. As I said, she was high preeclampsia risk, had been started on aspirin already, and she had a high BMI. So our immediate management, the patient's bloods were fine. Her full blood count was normal. It's important that she stayed on aspirin for reasons of placental development and early pregnancy, preeclampsia. But I explained to the patient that there was a literally 100% chance that this could happen again and affect her baby. So we needed to do everything we could to minimize the risk of this happening during this pregnancy. So this is where we liaised a lot with the tertiary centre about how to manage it. This time, I wanted her to be delivered at the baby to be delivered at the tertiary centre rather than locally, so that they had access to specialised tests and specialised platelets. And I referred the patient formally to Oxford, although we shared her care. So when deciding sort of the risk in these patients, it's a lot of the time based on how things have gone during a previous pregnancy. So this lady was deemed to be standard risk because during the delivery of her first baby, there was no intracranial bleed, and the baby turned out to be fine. So this time, what we tend to do is start patients on IVIG, which sort of helps to kind of reduce the antibody in the mother and hopefully helps support the development of platelets in the baby. So she started at a dose of 0.5 grams per kilogram every single week, starting from 20 weeks, and that was dosed on her actual body weight. And we were administering that in the local hospital, rather than making her travel sort of the 30 or 40 miles or so to Oxford. And she tolerated this quite well, no particular side effects. And she was having monthly ultrasound scans to assess how baby was doing. But unfortunately, at 29 weeks, the ultrasound did show changes suggestive of a fetal intracerebral hemorrhage. She went on to have an MRI, which confirmed that, but it was shown to be stable. So her dose of IVIG was increased. It was doubled to 1 gram per kilogram per week, and this was continued until the time of delivery. We did discuss with the patient whether she wanted to proceed with pregnancy, and she did. At the time of delivery, she had a son born by cesarean section, elective cesarean section at 37 weeks, and the mother's platelet count was normal, as you would expect. There was about a 500 ml estimated blood loss. Baby was empirically given special HbA1a negative platelets. We don't know exactly what the platelet count was before that, but it's likely it was in single figures. And after those platelets were given, the platelet count was 50. The baby then had an ultrasound and MRI, which did demonstrate a further intracerebral bleed. And the baby was given 5 more specialized platelets, as well as tranexamic acid to try and sort of maintain or minimize any further bleeding. And the platelet count did eventually recover as all that antibodies cleared and as these platelets that are going to bypass the antibody are actually taking effect. And it had normalized within 2 weeks of delivery. I've seen the patient sort of postpartum, and luckily both she and the baby are actually doing well. Baby was seen locally in a pediatric clinic about 3.5 months and developing well, developmentally progressing well, achieving developmental goals, normal muscle tone and movement, feeding well. So that all sounds really positive. Again, we counselled the patient about the need for early specialist input in the event of any future pregnancy. And another time, she'd obviously be considered high risk. And in that situation, we would start IVIG earlier and potentially at a higher dose, so from 12 weeks. But the patient doesn't want any further children at the moment. She's had a coil inserted. So the learning points from this are really sort of the causes of low platelets in a neonate, of which there are many, but sort of the most common one is sepsis and infection. You can differentiate to some degree by looking at, by assessing the baby. If there's a sick baby, think sepsis, think DIC, think necrotizing enterocolitis. Well baby, think could this be immune? Either what we've talked about with neonatal alloimmune thrombocytopenia or immune thrombocytopenia, maternal immune thrombocytopenia. If there's a small baby or there's been intrauterine growth restriction, then perhaps the most likely thing is placental insufficiency. A good obstetric history may detect previous immune issue in a previous pregnancy. So the things that are helpful to establish is, what's the mother's platelet count? If that's normal, then it's obviously far less likely to be maternal ITP, or it's not maternal ITP. What happened during the first pregnancy? How severe was the platelet count? Were there any other reasons it was low? How was it managed? And I suppose if you pick up a patient with this kind of background, the best thing we can do is monitor and plan for delivery. So if we've got this knowledge ahead of time, then doing what we can to have platelets available, have drugs available to minimize minimize any bleeding. So tranexamic acid, where that's possible. I don't know about access to IVIG, but certainly sort of that's what we would do. And that's the end of the talk. Is there any comments or questions?
Thank you, Rachel. I don't know, are you able to, I don't think I was able to comment from your end, Orton. I'm not sure if your microphone's working, but are there any questions from your end? How often do you, I'm interested to know from the team in Zambia, how often you come across babies born with low platelet counts and what the approach would be if this happened in your centre in Lusaka. I don't know if you're able to answer. I'm not sure how well the audio is working. Okay, I'm not sure we're going to manage to get any audio today.
Okay.
As ever, if there are questions, though, feel free to email them to me, and then we can distribute them to the speakers if there are any questions based on the talks. And as ever, the talks will be available on the BSH website for yourself and colleagues to access. Just one quick apology: we hadn't factored in last month. I'm sorry, the change in the British summertime and the change in the clocks that happens in the UK. So I think we got a little bit confused about our timings. But going forward, we'll from the next month onwards, we're going to keep the meeting at 11:30 a.m. Zambia time because I think that fits with your timetables better, and we'll alter our times at our end to accommodate that. So thank you, Rachel, for coming and speaking today, and thank you for everybody for attending. And we'll see you all next month.
Thanks.
Thanks,
Bye.
Thank
bye.
you very much. Thank you.